Hello and welcome everyone. Today we'll be discussing about POCUS in cardiac arrest, the practical aspects. POCUS is a bedside diagnostic tool used to differentiate causes of shock and managing the cardiac arrest. It is widely available in the ICUs, perioperative settings, and involve handheld devices, making it practical to use in emergency locations also. Various guidelines have been published by various societies which support the use of POCUS in cardiac arrest. However, clinicians must avoid pause of longer than 10 seconds in chest compression while using ultrasound. It is also integrated in the ACLS. In 2018, POCUS was added as a step in the pulseless electrical activity or asystole algorithm in the ACLS for perioperative cardiac arrest. It helps identify reversible causes of cardiac arrest, improving diagnosis in surgical patients. So the application is that it can predict ROSC in PA cases. Survival prediction post-cardiac arrest remains unclear due to limited data from randomized trials. There is a risk of delaying CPR if ultrasound use is not efficient. Several protocols exist to integrate ultrasound into ACLS. Now there are some basic terminologies like FOCUS, that is focused cardiac ultrasound. It is a quick two-dimensional grayscale B-mode scan performed by clinicians with basic training. Limited number of cardiac views used to assess life-threatening conditions. Echocardiography, it is a more advanced study involving additional tools like Doppler imaging. Helps quantify cardiac function and detect complex pathologies. Requires specialized training and is often consultative. So there are two conditions like pulseless electrical activity and pseudo-pulseless electrical activity. In pulseless electrical activity, you will find organized rhythm on ECG but no pulse, with no cardiac contractility on ultrasound. It is common in in-hospital cardiac arrest with almost 80% of the non-shockable rhythm being PEA, and it can be confused with ventricular fibrillation in ECG, but the ultrasound can differentiate. Asystole is not always true asystole. 10 to 35% of the patient in asystole may actually have cardiac motion. What is pseudo-pulseless electric? It is an organized ECG but preserved cardiac contractility seen on ultrasound, although it is too weak to generate a palpable pulse. The valve motion alone is not contractile. Passive flow across the valve movement can be seen. Better prognosis than true PEA, more likely to achieve ROSC during an ACLS. Meta-analysis show there is 95% sensitivity and 92% specificity when cardiac motion is seen. And some studies suggest ultrasound finding may predict mortality better than survival. Ongoing research aims to determine whether absence of cardiac motion will reliably predict failure of CPR. So how can we use ultrasound in narrowing the differential diagnosis of the cardiac arrest, that the 5H and the 5T algorithm that we use? So clinical application is to identify a cause between the 5H, 5T, help differentiate true PEA from pulseless pseudo-PEA, guide interventions like pericardiocentesis in tamponade, improve diagnosis of reversible causes, which is critical in non-shockable rhythms. So we'll start with tension pneumothorax. It is air trapped in the pleural space, and its mechanism is compresses the lung and mediastinum, reducing the venous return. It is exacerbated by the positive pressure ventilation. It can lead to cardiac arrest. The ultrasound diagnosis is done because it is more sensitive than a chest X-ray, which is going to take time, and it is performed a apical or a lateral lung scan during CPR. Findings that rule out a pneumothorax is the presence of a lung sliding, that is the movement of pleura, B lines, and pulse, that is lung pulse, transmission of the cardiac motion on the pleura. So to manage this, what we do is we immediately do a needle decompression or a chest tube. Be aware that hypogenic pneumothorax from rib fracture during chest compression can also happen. Myocardial infarction. MI is the most common cause of certain cardiac death. The role of focused cardiac ultrasound is important because it can detect pseudo-PEA. Identifies left and right ventricular hypokinesia such as ischemia, cannot confirm MI but suggests coronary thrombosis or vasospasm. Severe regional wall motion abnormalities considered anticoagulation and cardiology concern. Ultrasound should be repeated post-resuscitation to detect structural complications. Left ventricular free wall rupture, which is a sign of poor prognosis, can also be identified. Papillary muscle rupture can also be seen. Hypovolemia. Signs of hypovolemia in ultrasound are small ventricular chambers, collapsed IVC. In trauma and surgical patient, the collapsed IVC can also suggest hemorrhage. The limitation is the ventricle size does not always correlate with blood volume. Right ventricle can appear dilated in cardiac arrest, including hypovolemia. IVC variability is unreliable in mechanically ventilated patients on high tidal volumes. Now, FAST scan can detect free fluid in trauma cases. Emergency laparotomy or thoracotomy is needed if hemorrhage is confirmed. Acute obstruction in the right ventricular failure. The causes are pulmonary embolism, pulmonary hypertensive crisis. The ultrasound features can be dilated RV, the four chambers, flattened septum, that is the T sign, reduced right ventricular systolic function, TAPSE less than 17 millimeters. And in this, to differentiate between PE and pulmonary hypertension, pulmonary embolism is an acute event, thin walled dilated right ventricle. Normal sized right atrium is seen. Pulmonary hypertension, which is a chronic disease, the right ventricular wall thickening is seen, and right atrial enlargement is seen. So, pulmonary embolism is a common cause of cardiac arrest. So, how do we find it out? The diagnostic challenge that we can face is we cannot directly visualize the thrombus, and right ventricular dilatation and dysfunction is low sensitivity. The management consideration is look for a DVT in the lower extremity during the CPR. If DVT is found, consider empirical thrombolysis if CT angio is not feasible, and consider fat or gas embolism with embolic symptoms. Hypoxia. Hypoxia is a leading cause of in-hospital cardiac arrest, around 15 to 40%. It is severe and untreated hypoxia can lead to bradycardia and PA. Ultrasound helps identify the cause of hypoxia by securing airway and providing adequate oxygenation. The findings that we can find are diffuse B lines, non-specifically seen in ARDS pulmonary edema, focal B lines or pleural effusion or lung consolidation such as of pneumonia, pleural effusion which is a hypoechoic collection, lung consolidation that is tissue-like lung appearance. So what are the various protocols? Ultrasound should complement, not interfere with the ACLS. Multiple protocols exist, each focusing on different scanning priorities. It should focus on avoiding delays in the chest compression. So the early protocols that were used are the FEAR, that is focused echocardiographic evaluation in resuscitation, the first protocol for ultrasound in cardiac arrest. It includes a stepwise approach and a timekeeper. The major issue was interruption in the pulse check and delaying CPR. The next is FEEL, that is focused echocardiography entry level protocol. It is a training protocol in emergency and critical care. The study found that POCUS changed management in 70% of the pre-hospital ACLS cases. Next, we have multiple expanded protocols, that is CAUSE, CASA, PEA protocol, SESAME. Now, they were looking at various aspects. The challenges with this multiple protocol is that it creates a confusion. We will show you the table. Some protocols start with lung, vascular, and abdominal scans, but cardiac imaging can provide highest diagnostic yield first. The need for efficacy and safety is to be considered. So the new protocols which are more focusing on cardiac arrest, that is the shock protocol, it focuses on the 4 F's, that is fluid, form, function and filling. So they look for pericardial fluid, ventricular form, and the optional views are pleural effusion and pneumothorax and peritoneal free fluid. Then other one is the echocardiographic assessment under subcostal view. This again doesn't all the time interfere with the compression, and with just one UV you can get a lot of things and you can help classify the shock. So these are the various protocols, the year they were published, the sequence detailed, and who should do it and what are the distinguishing features. You can go through it because it is extremely detailed and you need to know each aspect. Regarding the safe implementation of POCUS, the ultrasound can prolong the CPR interruption. Some studies show increased pulse check duration. When compared with trained ultrasound expert, the median pulse check was reduced by 4 seconds. Ideal scenario would be the most experienced person should acquire the images. Interpretation does not require high expertise. Trained residents can diagnose key pathologies as quickly as board certified cardiologists, because getting the image is important. The interpretations is pretty easy because you are actually seeing something. So the strategy for safe POCUS should first focus on a structured and systemic approach, avoid random scanning, use an established protocol, Aim for a 10-second pulse check interval. Now, team coordination is important. Assign a team keeper to check for these seconds and counting out loud. Ultrasound operator should announce findings briefly and clearly, discuss potential interventions without delaying CPR, repeat ultrasound after ROAC, which is very, very important, which considers radiotherapy. Now, next thing is the preemptive ultrasound for unstable patients. If your patient is very unstable and high risk, you can do that ultrasound before also. So it is useful in the post cardiac arrest, post anesthesia care units. Compression, the chest compression hand position can be confirmed here by the ultrasound, and the studies show that the internipple line is often over the aorta and not the heart in 80% of the cases. Moving compression to the xiphoid region may increase stroke volume. Reduce false positive and negatives in the pulse detection. Manual pulse palpation is unreliable with specificity as low as 70%. Ultrasound is more accurate in these cases. TE, it can be used. The advantage is that it can be performed without interrupting the CPR, and it detects cardiac pathologies as surface ultrasound. Improves compression effectiveness by confirming the optimal hand position. The limitations being that it has to be inserted before, you can't do it during the CPR. It cannot assess the lungs, abdomen, and the lower extremity, which can be the source of the problem. Best used as an adjunct, not as a replacement. The safety is important, very low risk, but if it is prior placed. So if it is placed, then it's okay, but then doing it later is going to be a problem. The future research and guidelines, the POCUS is endorsed by the ACLS guidelines. Ultrasound technology is more accessible now in the hospital. Portable devices are easily found. Current research should focus on randomized trials, which have been underpowered, so better powered trials. Future trials will focus on endpoints, identifying reversible causes and effective resuscitation strategies. Training efforts should expand beyond resident fellows to include attending anesthesiologists and surgeons. Clinician familiar with the patient history is well positioned to use ultrasound for precise differential diagnosis and targeted resuscitation, because history is paramount. Without history, we are just blind. So the take-home message is that use POCUS to refine your differential diagnosis in cardiac arrest, avoid delaying CPR, keep the interruption less than 10 seconds, assign a timekeeper who will count out these seconds loudly and prevent long interruptions. TE can be helpful, but if it is previously placed and it's not a replacement for surface ultrasound. Preemptive ultrasound for unstable patients should be done so that you have a prior idea where the problem is going to be happening. Training and focusing the ultrasound in critical care for all providers is paramount important. Thank you for your patience.